Hi everyone, welcome to the channel. This is the first video in rapid revision of rheumatology, and we'll be discussing allergy, immunology and rheumatology in this series. So without further delay, let's look at the first topic, that is diseases of immediate hypersensitivity. These are the diseases which result from immediate release of immunoglobulin E dependent mediators. These mediators are released from basophils and mast cells on direct contact with the offending agent. This offending agent is often called allergen or even called antigen. So the disorders in this category include anaphylaxis, allergic rhinitis, urticaria, IgE dependent asthma, eczematis or atopic dermatitis. Let's now look at the pathogenesis of these diseases. Immunoglobulin binds to the mast cell or basophil surface through high affinity receptors. Cross-linking of these immunoglobulins to antigens leads to release of stored and newly synthesized mediators from mast cells and basophils. These released mediators cause important effects including vasodilation, increased vascular permeability, smooth muscle contraction, and even chemotaxis of other inflammatory cells, leading to further inflammation. Clinical features depend on the anatomic site of release of mediators and duration of release. These IgE dependent mediators of inflammation are divided into lipid mediators, secretory granule preformed mediators, and cytokines. Lipid mediators include leukotriene B4, C4, platelet activation factor, and prostaglandin D2. Secretory granule preformed mediators include histamine, proteoglycan, tryptase and chymase, carboxypeptidase A. Cytokines include interleukins 1, 3, 4, 5, 6 and 13, interferon gamma and TNF alpha, GM colony stimulating factors and chemokines. Combined, they have 4 important actions in inflammation. These are leukocyte responses, fibroblast responses, substrate responses, and microvascular responses. Leukocyte responses include adhesion, chemotaxis, IgE production, eosinophil activation, and mast cell proliferation. Fibroblast responses include proliferation, vacuolation, production of collagen, and globopentosyl ceramide production. Substrate responses include matrix metalloproteinases activation and activation of coagulation cascade. Microvascular responses include dilation, increase in venular permeability, leukocyte adherence, and constriction. With this in mind, let's now look at the first subtopic of immediate hypersensitivity, and that is anaphylaxis. Anaphylaxis is a life-threatening systemic hypersensitivity to contact with an allergen. It can occur within minutes of exposure to offending antigen. Any antigen can cause anaphylaxis, but some of the classic examples include Antisera, pollens, Hymenoptera, venom, antibiotics, IV contrast media, and also some hormones. In clinical features, most of the patients have a uniphasic presentation where the disease occurs within minutes of exposure. This contributes to about 90% of the cases, whereas a small 10% of the cases can have biphasic presentation where the initial symptom are followed by normalization and there is a recurrence of anaphylactic symptoms after 1 to 2 hours of initial exposure. The symptoms can be divided into respiratory, cardiovascular, and cutaneous. Respiratory symptoms include swelling of mucous membranes, stridor, hoarseness, there can be wheezing, and there can be difficulty or dyspnea on exertion. Cardiovascular symptoms include tachycardia and hypotension. Here, the hypotension can be due to a vasodilation. Cutaneous symptoms include pruritus, urticaria, and angioedema. The diagnosis is usually clinical and requires emergency interventions with securing of airway, resuscitating from hypotension. The first choice agent for treatment of anaphylaxis is epinephrine, which is given at a dilution of 1:1000 in a quantity of 0.3 to 0.5 milliliters intramuscularly. This dose can be repeated every 5 to 20 minutes depending on the severity of the symptoms. Patient should be placed in supine position to increase the venous return and prevent empty heart syndrome. The advantage of epinephrine is it gives both alpha as well as beta stimulation, where alpha stimulation causes vasoconstriction and beta stimulation causes bronchial smooth muscle relaxation. Supportive therapies include fluid administration, and choice of agent is normal saline, and patients can be given vasopressors if the patient is unresponsive to fluid therapy. Antihistamines such as diphenhydramine in the dosing of 50 to 100 milligrams can be given intramuscularly or intravenously. Patients can also be given nebulized bronchodilators. Glucocorticoids such as methylprednisolone in the dosing of 0.5 to 1 milligram per kg can be given intravenously. This does not help in acute symptoms but has a role in reducing the occurrence of hypotension later in the disease. In patients with severe airway obstruction, endotracheal intubation may be necessary. Such patients might also require oxygen support as well as sedation. The next subtopic is urticaria and angioedema. Urticaria involves only the superficial dermis and it presents as pruritic, circumscribed wheals with raised and serpiginous borders along with a blanched center. Angioedema, on the other hand, involves deeper tissues. It presents as swelling of tissues and presents with pain more than pruritus. The recurrence of these symptoms can be divided into acute, which is episodes lasting for less than 6 weeks, and chronic, where the episodes are occurring for more than 6 weeks. Let's look at the acute causes and chronic causes of angioedema. Acute causes include drug reactions to non-steroidal anti-inflammatory drugs, IV contrast medias, angiotensin converting enzyme inhibitors and other medications. Certain foods can cause acute presentation. Exposure and inhalation of certain environmental agents or even allergens can cause acute presentations. Transfusion reactions and even viral, bacterial or parasitic infections can cause acute presentations. Chronic presentations can be idiopathic with autoimmune component. Collagen vascular disease such as urticarial vasculitis, physical stimuli which include dermatographism, cholinergic urticaria, vibration, cold, pressure, and even exposure to water, which is called aquagenic urticaria, even long exposure to sun called solar urticaria. Other causes include mastocytosis or Urticaria pigmentosa. Hereditary causes include hereditary angioedema, C3b inhibitor deficiency, familial cold urticaria, Muckle Wells syndrome, Schnitzler syndrome, Gleach syndrome, and hypereosinophilia syndromes. Among the chronic idiopathic cases with autoimmune etiologies, some patients are shown to have autoantibodies against immunoglobulin E. Hereditary angioedema is a autosomal dominant familial angioedema disorder which is caused by mutation in SERPING1 gene that leads to C1 esterase inhibitor deficiency in 85% of the cases, and these are called type 1 hereditary angioedema, or it can lead to a dysfunctional C1 esterase inhibitor, which is type 2 hereditary angioedema. Classically, these patients have a family history of angioedema episodes with a striking absence of urticarial lesions. In diagnosis of urticaria and angioedema, it is important to take the history, especially with focus on possible exposure to allergens or ingestion of such antigens. Urticarial Eruptions usually last for 12 to 36 hours, where the old lesions fade as soon as the new lesions appear. In physical urticarias, individual lesions last less than 2 hours, and if the lesions are lasting more than 36 hours, they are more painful and less pruritic, and these lesions warrant a skin biopsy to rule out or rule in urticarial vasculitis. These patients also have a tendency to scarring at the site of urticaria. For angioedema, the common sites are periorbital and perioral. Respiratory tract involvement can become life-threatening. Specific tests include allergen testing with various foods or pollens and certain common chemicals. This is performed as a skin test. In physical urticaria, direct reproduction of lesions is important basis for diagnosis. Laboratory investigations include complete blood counts where there may be eosinophilia. Erythrocyte sedimentation rate may be increased. In patients with suspected hereditary angioedema, patients can be subjected to C1 esterase inhibitor levels and complement levels. Other special tests include serum allergen specific IgE levels, mast cell studies, cryoglobulin levels, hepatitis screening, autoantibody screening, and skin biopsy. Differential diagnosis include atopic dermatitis, contact sensitivity, cutaneous mastocytosis, and systemic mastocytosis. Let's now look at the treatment of angioedema and urticaria. H1 antihistamines such as chlorpheniramine or diphenhydramine can be used, but these come with a significant sedating side effects. There are other low or non-sedating options in H1 antihistamines: cetirizine, levocetirizine, desloratadine, fexofenadine, loratadine, etc. Addition of H2 antihistamines to H1 antihistamine therapy are shown to have improved outcomes, and these examples include ranitidine, cimetidine, famotidine. It is important to note that H2 receptor antihistamines are themselves not very effective in treating urticaria, but when they are added with H1 antihistamines, they are shown to have improved outcomes. Older agents with antihistamine properties include doxepin, cyproheptadine, hydroxyzine. These agents are typically used when H1 antihistamine are not adequate. Cystinyl leukotriene receptor 1 antagonists such as montelukast can be used as a add-on therapy. The dosing options are montelukast 10 mg once daily or zafirlukast 20 milligrams twice daily. In chronic urticaria that are showing inadequate response to anti-H1 therapy, can be given omalizumab, which is a anti-IgE monoclonal antibody in patients who have shown inadequate response to H1 therapy given QID with an add-on leukotriene receptor antagonist therapy. Omalizumab, which is a anti-IgE monoclonal antibody, can be used. Topical glucocorticoids are of no value in urticaria. Systemic glucocorticoids are not recommended in idiopathic cases and allergen induced or physical urticaria. However, in patients with urticarial vasculitis, unresponsive chronic urticaria, and idiopathic angioedema without urticaria, systemic glucocorticoids can be used. In treatment of hereditary angioedema for acute patients or for prophylaxis, infusions of isolated or recombinant C1 esterase inhibitors can be used. Other treatment options in acute hereditary angioedema include bradykinin 2 receptor antagonist, icatibant, or kallikrein inhibitor, ecallantide, can be used. The next topic is allergic rhinitis. This condition is characterized by sneezing, rhinorrhea, obstruction of nasal passages, pharyngeal, nasal, and conjunctival itching, and lacrimation. All of these symptoms occur in temporal relation to the exposure to allergen. In patients who are allergic to pollen, this condition can be seasonal, whereas in patients who are allergic to dust, mite, and dander, can have a perennial symptomatic presentation. Pathophysiologically, the pollen or other allergens come into contact with nasal mucosa in sensitive individuals, resulting in IgE dependent triggering of mast cells, which further releases inflammatory mediators and causes development of hyperemia, mucosal swelling, and fluid transudation. The diagnosis is based on history. Physical examination of the nose may reveal boggy or erythematous nasal mucosa. Sometimes even nasal polyps are seen. Conjunctival inflammation or edema may be noted. Patients may have other coexisting allergic diseases such as urticaria or even asthma. Skin test can be done to identify the allergens. Nasal smears may reveal large number of eosinophils. Serum IgE, which can be either total or antigen specific, will be elevated. Treatment involves antihistamines, which can be both older generation or the new generation. Older generation comes with higher sedation, and they may also cause neurological effects such as reduced hand-eye coordination. Newer generation, including desloratadine, fexofenadine, levocetirizine, loratadine, all of these come with higher H1 specific actions, and they are less sedative. Oral sympathomimetics such as pseudoephedrine can be given in combination with antihistamines. A possible side effect of this class of drugs is aggravation of hypertension. Topical vasoconstrictors are shown to be of good symptomatic benefit. However, long-term use can cause rebound congestion, and these may also progress the disease to chronic rhinitis. Other medications include topical glucocorticoids, topical nasal cromolyn sodium, which is usually given as 1 to 2 drops in each nostril 4 times a day, azelastine, and even ipratropium can also be used as topical agents. Montelukast is also approved for seasonal disease, and in patients with failure to respond to therapy, hyposensitization can also be tried. The next topic is systemic mastocytosis. This is a systemic disorder due to the clonal expansion of mastocytes or mast cells. The disease is usually indolent and benign in most of the cases. Mastocytosis is divided into cutaneous form and systemic form. Cutaneous form has its own variants. Systemic form has 5 variants, which are indolent, smoldering, associated with concomitant hematological, non-mast cell lineage disease, aggressive systemic form, and mast cell leukemia, and a rare entity called mast cell sarcoma. The clinical features of systemic mastocytosis are due to mast cell accumulation within the tissue. The tissue response to mast cell accumulation is fibrosis, which releases accumulated mast cell granules, causing a local reaction leading to symptoms such as urticaria pigmentosa, crampy abdominal pain, gastritis, and peptic ulcer. This can also cause distant symptoms such as headache, pruritus, vascular collapse, and flushing. The symptoms worsen with exposure to alcohol, cold temperatures, with NSAID medications, stress, and narcotics. The diagnostic criteria for systemic mastocytosis has major criteria and minor criteria. Mastocytosis is diagnosed when patient has either one major criteria or 3 minor criteria. Major criteria is presence of multifocal, dense infiltrates of mast cells with more than 15 cells per aggregate seen in bone marrow or extracutaneous sites. Minor criteria are 4 in number. The first one being abnormal mast cell morphology with cells such as bilobed or multilobed cells or spindle shaped cells, cells with eccentric nucleus or hypogranulated cytoplasm. The second minor criteria is aberrant mast cell surface phenotype with expression of CD25, that is interleukin 2 receptor alpha chain, or cell may have CD2 expression. The third minor criteria is detection of codon 816 mutation in peripheral blood cells or bone marrow cells or extracutaneous cells. And fourth criteria is total serum tryptase more than 20 nanogram per milliliter. The differential diagnosis for systemic mastocytosis includes other conditions that can cause flushing, such as carcinoid syndrome and pheochromocytoma. So patient needs to be evaluated for these differentials, and only after ruling out these differentials can it be diagnosed as systemic mastocytosis. The treatment of systemic mastocytosis involves H1 and H2 antihistamines, proton pump inhibitors for gastric hypersecretion. Patients with abdominal pain or diarrhea can be treated with oral cromolyn sodium. In patients with severe flushing, oral aspirin can be used to block prostaglandin D2. In patients with malabsorption, oral or systemic glucocorticoids can be used. Patients with advanced or non-indolent diseases can undergo cytoreduction therapy, which is given by midostaurin, interferon alpha, or cladribine. Patients with frank leukemia are subjected to chemotherapy. In patients with very advanced mastocytosis, stem cell transplantation of bone marrow can be done. The next topic is primary immunodeficiency diseases. These are genetic diseases that can involve all parts of immune system or immune response, that is both innate and adaptive immune responses. It can also affect the cell differentiation and maturation. Let's now look at the classification of primary immunodeficiencies. The first one being deficiency in innate immune system. There can be phagocytic cell involvement in conditions such as severe congenital neutropenia. There is impaired production of phagocytic cells. Other conditions with involvement of phagocytic cells include asplenia. There can be adhesion defects in leukocyte adhesion deficiency, written as LAD in short. Impaired killing is seen in chronic granulomatous disease or CGD in short. Defects in innate immunity receptors and signal transduction is seen in defects in toll-like receptors signaling, and there is an increased Mendelian susceptibility to mycobacterial diseases. There can be complement deficiencies, and these can affect the classical, alternate, and even lectin pathways. This can also affect the lytic phase. Deficiencies in adaptive immune system. This can be broadly classified into T cell deficiencies and B cell deficiencies. T lymphocyte deficiencies can have impaired development, impaired survival of the T lymphocytes, and even impaired T cell migration. B cell deficiencies can also have impaired development and impaired functionality. The classic examples of deficiencies in adaptive immunity for T cell deficiencies include, or T cell defects include, severe combined immunodeficiencies, or SCID in short, DiGeorge syndrome. There can be thymic hypoplasia in these patients. Other examples include autosomal dominant hyper IgE syndrome, DOC8 deficiency, CD40 ligand deficiency, Wiskott-Aldrich syndrome, ataxia telangiectasia. Whereas for B cell defects, there can be X-linked or autosomal recessive A gamma globulinemia, hyper IgM syndrome, common variable immunodeficiency, IgA deficiency, regulatory defects. These are further subdivided into innate immunity regulatory defects and adaptive immunity regulatory defects. Common conditions where innate immunity is involved includes autoinflammatory syndromes, severe colitis, hemophagocytic lymphohistiocytosis, or written as HLH in short. Adaptive immunity defects includes autoimmune, lymphoproliferative syndromes, autoimmunity, and inflammatory diseases. Let's look at some of the important primary immunodeficiencies. In that, T cell immunodeficiency syndromes. The first one is severe combined immunodeficiency, or SCID written in short. This is a group of rare primary immunodeficiency disorders where there is profound block in T cell development due to intrinsic defects. Clinical symptoms are usually seen within 3 to 6 months after birth, and these include failure to thrive, recurrent oral candidiasis, protracted diarrhea, pneumocystis jirovecii, infections. There are 5 important causative mechanisms that are implicated: cytokine signaling deficiencies, purine metabolism deficiency, defective T and B cell receptor rearrangements, defective pre T cell receptor signaling in thymus, and reticular dysgenesis. In patients with absent T and NK cells, cytokine signaling deficiencies are the most common causative mechanism, contributing to 40 to 50% of the cases. These patients have deficiencies in gamma chain receptor that is shared by several cytokine receptors: interleukin 2, 4, 7, 9, 15, 21, etc. This is seen in patients with X-linked severe combined immunodeficiency as well. And in patients with autosomal recessive form, there can be a mutation in JAK3 gene, which can lead to a similar pathophysiologic mechanism of cytokine signaling deficiency. Purine metabolism deficiencies, approximately 20% of the patients have this pathophysiologic mechanism where there is a deficiency in adenosine deaminase, or written as ADA. This is due to a mutation in ADA gene. Defect in T and B cell receptor arrangements account for up to 20 to 30% of the cases. The mechanism here involves deficiencies of recombinase activating genes, that is RAG1 and RAG2 genes. Defective pre-T cell receptor signaling usually is a rare disease which involves deficiency or defect in CD3 subunit of CD45 or T cell receptors. Reticular dysgenesis is extremely rare and involves deficiency of adenylate kinase 2. The treatment in severe combined immunodeficiency is curative with hematopoietic stem cell transplantation. The other T cell related deficiencies include DiGeorge syndrome, where there is thymic hypoplasia, hyper IgE syndrome, CD40 ligand deficiency, Wiskott Aldrich syndrome, ataxia telangiectasia. In all these conditions, live vaccines and transfusion with live or viable T cell containing components should be completely avoided. Some patients with severe T cell deficiencies can be chosen for pneumocystis pneumonia prophylaxis. In certain conditions, hematopoietic stem cell transplantation is curative and it needs to be assessed case by case. Next, we will look at B cell diseases. These are the most common primary immunodeficiencies and they account for up to 60 to 70% of all primary immunodeficiencies cases. The defective antibody production increases the risk for invasive bacterial pyogenic infections and also increases the risk of sinus and pulmonary infections. A complete lack of antibody production, also called as A gamma globulinemia, can predispose the patient to severe life-threatening, disseminated infections, including meningoencephalitis, hepatitis, and dermatomyositis like disease. Here, the diagnosis relies on the assessment of the immunoglobulin level in serum. Now, let's look at some of the examples of B cell in primary immunodeficiencies, and the examples include A-gamma globulinemia. In about 85% of the cases of this, there is an X-linked mutation in Bruton's tyrosine kinase gene. Hyper IgM syndrome results in mutation in gene encoding CD40 ligand, where the patients have very high levels of IgM and almost absent or very low IgG and IgA immunoglobulin subtypes. Common variable immunodeficiency syndrome is a heterogeneous group of various syndromes with low serum immunoglobulin levels. These patients can develop infections but can also develop lymphoproliferative diseases, granulomatous lesions, colitis, antibody mediated autoimmune diseases, and even lymphomas. Isolated IgA deficiency is the most common immunodeficiency, and it usually affects 1 in 600 people. Even with an absent IgA, the patients may not be susceptible to infections. Some of these patients can progress to common variable immunodeficiency syndrome. Another example is selective antibody deficiency to polysaccharide antigens. Treatment for B cell primary immunodeficiencies include immunoglobulin replacement, which is usually guided by the presence and severity of infections, especially in patients who are deficient in immunoglobulin G. This replacement can be performed through subcutaneous route or intravenous route. IV immunoglobulin is replaced every 3 to 4 weeks with a target residual level of 800 milligram per ml. Subcutaneous injections are given typically once a week. However, the frequency can be adjusted. A trough level of 800 milligram per deciliter is desirable. Now let's look at some of the important diagnostic tools that are utilized in assessment of primary immunodeficiency syndrome. The first one is blood cell counts. There will be neutropenia in severe congenital neutropenia. Lymphocyte count can be increased in leukocyte adhesion defects or deficiencies. It can be reduced in T cell immunodeficiencies. Eosinophils can be increased in hyper IgE syndrome. Howell Jolly bodies can be seen in Wiskott-Aldrich syndrome and even in asplenia. Chest X-ray is an important tool in DiGeorge syndrome, where there can be absence of thymic shadow. In patients with ADA deficiency leading to severe combined immunodeficiency, there can be costochondral cupping. Bone X-ray to look at the metaphyseal ends. is performed in cartilage, hair, hypoplasia. Serum immunoglobulin levels are measured in patients with common variable immunodeficiency or B cell immunodeficiency syndromes. There can be increased IgE level seen in hyper IgE syndrome, dihydrorhodamine fluorescence or DHR assay is performed in patients with chronic granulomatous disease where deficiency of enzymes in polymorphonuclear cells can lead to lack of reactive oxygen species production. Even nitroblue tetrazolium assay is performed for the same reason. CH50 and AP50 assays are done in patients with complement pathway defects or in patients with complement deficiencies, and ultrasonography is done in patients with asplenia.